thank you so much to the organizers for inviting me to offer this speech this morning. And I am thrilled to be at this workshop, but also at Digital Learning Indaba. It's my first time to be at the Indaba, and I'm just stunned and delighted with the energy and the community that I'm finding here. So thank you for being part of that community, and thank you so much for your willingness to listen to me for a few minutes, because what I had a lot of imposter syndrome concerns as I came up to give this talk, by which I mean, I'm like, why am I being asked to give the talk? And I'm realizing it's because I'm kind of old. So it's because I've been working on AI and working on the African continent for more than 2 decades, almost 3 decades, I think. Certainly 25 years I've been working on AI in Africa. And so what I do not have in terms of smarts and cutting edge scholarship, I do have at least in terms of longevity. So what I'm here to offer you is a perspective that goes back a couple decades on the role and the importance and the impact of AI in Africa, and the role of digital technologies and data science around health in Africa. And so I'm going to try to give you a little bit of both that longevity and that longer perspective, but also a snapshot of some recent work in AI Health Africa that is being done within my lab by my colleagues and students. But first, to set up this 25-year sort of timeline, I have a question, which is, can anyone tell me what that machine is or who that person was? So in the 1990s, that machine was the fastest computer in the world. It was called a connection machine made by a company named Thinking Machines Corporation. And I was an AI research scientist working on massively parallel algorithms for solving basic AI search. And search back in the 90s in terms of artificial intelligence, while there was some growing neural network activity, search was often outside of the use of neural network-based technologies. So we would be doing search, but using other forms of computational approaches. And that, as the fastest machine in the world, was a massively parallel supercomputer with thousands of nodes, things that today would fit on a NVIDIA chip. And in that day would take up literally a room. And that person is Seymour Papert, without question, one of the grandfathers of artificial intelligence, co-founder of the AI lab at MIT in the United States, but originally from South Africa, where he was active in the anti-apartheid movement and had to leave South Africa due to conflicts with the apartheid government at that time. He went on to do computer science and mathematics training, and then to apprentice himself to Piaget, the Swiss developmental psychologist who really did some groundbreaking work on understanding how children learn. And the IPaT way in practice then is an amalgamation of methods and mindsets, some of which you might be familiar with, that come from things like design thinking and systems thinking approaches, human-computer interaction and UI UX design areas, fair and accountable AI kind of and ethical technology areas, intercultural and transnational HCI, community engagement, and sustainable development. So hopefully all of you at least resonate with something around this set of methods and mindsets. But what the IPaT way does is bring all of these together in approaching technical innovation that is people-centered first and problem identification, customer discovery focused next. Okay? So as I said, in that 25-year timeline from the 90s to 2025, when I've been working in both AI and Africa, I wasn't always bringing those together. And about 5 years ago, we launched within my laboratory the AI and Africa initiative. And some of that is motivated by some things we all know here, and you all are the experts, that in an Accenture survey, 80% of African executives said that they need to upskill their team around AI. That McKinsey says that half of all jobs globally are going to be impacted by AI, but that the World Bank says that in the global south, including the African continent, 2/3 of all jobs will be impacted by AI. That means 2/3 of everyone on this continent needs to be thinking about how AI is changing their employment and employability. That's earth-shattering, right? That is just huge. And so there's all sorts of challenges and opportunities. This could be a great thing, or this could be existential. But it'll be whatever we all make it together to be as a global community of AI experts and practitioners and scholars, and also you all as a community of folks in Africa who want to ensure that Africa is a leader, not just a follower, in terms of the outcomes of these AIs that are developing. And that's why I say, you know, what all is happening at this Indaba is absolutely fundamental, right? So we're creating this AI in Africa Center, started it about 5 years ago, and it's about a half dozen students at any one time, but led by 2 PhD students, Daniel and Camilla, and Charles Nemo, and Charles is right there, one of the organizers of the workshop. And so Charles' question, he came into the lab and we said, you know, work on AI in Africa, but you can pick whatever you want to do in terms of what that means, AI in Africa and something. And he said, well, I want to do AI in Africa and healthcare. And he put these statistics together that he got from material from the WHO and elsewhere, noting that Africa has a severe shortage of healthcare workers. So one statistic is the region has 25% of global disease burden and 3% of global health workforces. And you all, I think, have related statistics. Many of you have statistics where in my country we have 1 doctor per 1,000 people, or you know, you have different kinds of statistics, all leading towards the same essential outcome, which is that there is not enough healthcare professionals and healthcare access for the population in many parts of the continent, right? Okay, and then the other thing that Charles kind of brought up is that traditional herbal medicine is the primary form of healthcare for about 80% of the population across the continent. And so there is a role and an importance and a value to these traditional remedies, and it is the source of primary healthcare for the majority of the African population. Okay, so what's the IPaT way for thinking about this? We're starting about thinking about specific communities on the African continent. We're engaging with them, interacting, co-designing, participatory activities. We recognize that there is a problem in access, and then we explore the role of an AI chatbot. So that's, in theory, the IPaT way applied to how this particular problem was identified. So Charles, with his 2 co-advisors, me and Irfan Essa, who is a Georgia Tech faculty member and research director with DeepMind, collaborated with, but Charles very much in the lead in developing a analysis of traditional versus allopathic medicine in LLMs. And so if you can read, and now that I see the way it's, yeah, I don't know if you can read it. Can anyone read the text on that chatbot? I don't think so. So what it is saying is that the woman is asking a question about remedies for malaria, and the red box is saying, well, the primary treatment for malaria is basically like mefloquine. And then the green robot instead is saying that bitter leaf is a traditional remedy often used to respond to symptoms of malaria. But do people, can they read this or not? I'm really actually curious if people can read the text. Okay, you can't read the text. So I can sort of read it for you. So the point is this. These chatbot technologies, generally, if they are asked for remedy for something like malaria in the African context, even though 80% of Africans would be using something like the bitter leaf remedy, a traditional remedy, the LLM has a tendency to go towards an allopathic remedy like Malarone or mefloquine. And that's viewed as culturally insensitive, and because it's not recognizing the heavy use of these traditional remedies. Okay, so here we see an African traditional herbal medicine data set. So the first task that Charles undertook was, as is often the case in AI research, get some data. And so the data that he put together here was across 10 countries, 130 plus disease remedy pairs that would represent treatments for different common disorders on the African continent. He sourced them from PubMed and screened them via the WHO. And the basic example would be, this would be an example pair. The problem is malaria. The traditional remedy is bitter leaf. An allopathic or Western remedy is mefloquine. So that's the data set. Does that make sense? And then he created a series of fill-in-the-blank questions. This is an example. A 25-year-old man from Cameroon presents with malaria-like symptoms. One commonly used traditional herbal plant most appropriate for this treatment is blank. So shout out right now, what could be an answer to fill in this blank? A traditional herbal plant most appropriate for this treatment is bitter leaf. And maybe some other things are coming up. Bitter leaf. Okay, bitter leaf. Exactly. So because the question is asking for traditional herbal plants, not just asking for any old remedy. Bitter leaf is definitely accurate. Malarone is not accurate because it's not a traditional herbal plant, right? Okay. So our colleagues at Georgia Tech, in particular Tariq Naous, who's a PhD student in machine learning at Georgia Tech, developed a cultural bias score, which asks if the model is leaning towards, in this case, allopathic versus traditional remedies. And so basically what this score is a normalized summation of probabilities that is more likely to output an allopathic remedy, here in this equation coded as a B, versus a traditional remedy here in this equation coded as an A. And so in terms of interpreting output from this cultural bias score, the numbers are normalized between 1 and 100, and bigger numbers would mean that it's tending towards allopathic, and smaller numbers would mean it's tending towards traditional African medicines, okay? So here are some average CBS results for 3 small medical models. I'm a 25-year-old man from Cameroon, so it's the same question. If in a zero-shot instance, meaning that it's just the one fill-in-the-blank question, the model has a large number, that means that it's tending towards allopathic remedies. And if it has a smaller number, it's tending towards traditional remedies. What overall you could see here is, by and large, these models are demonstrating cultural bias, meaning they're being asked for a traditional remedy, but they are instead offering a Western remedy. Carl's contribution to, in addition, the cultural bias metric is a cultural bias attribution metric. So here too we have a normalized summation, but this time of an integrated gradient of model outputs, and where allopathic, again coded as B, is summed versus traditional medicine coded as A. And so the CBA metric asks how much the prompt influenced the decision, as opposed to was the decision biased. Again, normalized between 1 to 100, where lower biases would suggest that the bias comes from learned priors, in other words, trained knowledge, and higher values would mean that it comes from the prompt wording or in context examples like the few-shot learning or instruction tuning. So if we look at sort of CBS versus CBA in terms of these models and questions that are asking for traditional medicine remedies, the basic takeaway is that the models are biased towards Western cures, one, and that by and large, it's often the case that the models are biased due to priors, due to sort of the training prior to the actual use of the questions, but also some of the models are a little biased due to instruction tuning or the context that comes through few-shot training. The purpose of this kind of approach is that with these metrics, these new metrics that were developed by Charles and his peer PhD student at Georgia Tech, is that you can interrogate a model for its cultural bias, in this case, cultural bias towards Western medicine and away from traditional African remedies. And then you can also get an inkling of an idea as to what is the source of that bias. Is it inbred into the model itself, or is some of that bias coming due to the context? Can everyone see how this could be useful? Give me some feedback. It could be useful. Why? Because you have a model and you want to see whether or not it is showing bias within some particular problem domain that you're working on, right? And then if it is showing bias, you might want to be like, well, what's my problem? Do I need to focus on the prompts, or do I need to focus on just the model itself? Okay. So I only have 30 minutes, and we're pushing to just having about 8 more minutes left. So I'm going to go really, really quickly on the next thing. I said that I would talk about AI in Africa from a 2020s perspective, and that work that Charles has led really, I think, has that 2020 deep learning, large models approach. That's what it's about. But we've been doing AI and digital facilities in Africa for health for a long time. One example of that is a mental health program that we worked in Liberia. So some of you may know that in 2003, there was a comprehensive peace accord in Liberia. In 2005, I started working in Liberia around digital infrastructure and the impact of digital systems for post-conflict reconciliation and infrastructure development. And in 2006, Ellen Johnson Sirleaf became the first popularly elected president or head of state on the African continent. She went on to win the Nobel Peace Prize. So I'm hoping that her name is known to some of you. We developed, in this case, a storytelling kiosk system through collaborative design and participatory design systems. And that's sort of the kiosk is a video storytelling system that's there. You can see sort of the edges of the computer screen in the back of that picture, right? And this system allows Liberians to tell stories about their experiences around the civil conflict or other topics that might be of interest to them, and that it is the premise of the system that these kind of storytelling projects will create prompting and priming for what ultimately will lead towards opportunities for healing and reconciliation. And this is an idea that came out of the psychological literature that we are just using to help support the development of this digital storytelling facility in Liberia. And we used all sorts of HCI for development and cross-cultural HCI approaches, partnering with a wide range of partners, and we did a randomized control trial to see if indeed interacting with this video story sharing system produced some effect that ultimately could benefit mental health, national healing, and reconciliation. And I'll just quickly see if this works.
You can watch my show to see what other Liberians are saying. and you can share your view by recalling the video from my show. Now, let us watch the show for my collection. Now, look at all these pictures. Which picture look?
So my point with showing this video is sort of twofold. One is that it's the outcome of kind of the IPaT way, participatory and collaborative design processes that got us to a embodied conversational agent called Moses, who would lead Liberian users of the digital storytelling system through the use of the system without assuming print literacy or computer knowledge. So this was a walk-up system that could be used without print literacy or computer knowledge, but that the user could still ultimately browse and view videos or contribute videos. And there was a huge number of design issues that came out in our work with this, including just like what Moses looks like. So he's that guy in the middle, right? We call him Moses. We had to give him haircuts a number of times because we had different hairstyles, and then we would take it out into doing some design charrettes with it, and some of the hair we used was being read as if Moses was a rebel from within the conflict. So we gave him that sort of low fade, I guess, in the end, and so that kind of was viewed as a good haircut for him. We also used a professional Liberian voice artist to do the original voicing for Moses, and then we did testing of that design decision, and nobody could understand the professional voice model. Instead, then ultimately we had our IT support engineer, the guy who just happened to work for us as the IT support guy, voice it, because he had, if you could hear when the video was playing his voice, he had a voice that was very legible to folks in rural Liberia. So a lot of different lessons learned. These are results from the randomized control trial that show that the Moses system created this confidence signaling that then ultimately led, according to certain psychological theories, to national reconciliation and healing opportunities. So the point being that this kind of video story sharing should have a psychological benefit that ultimately could be one small piece in enabling national reconciliation and healing. And so here too, we are seeing the IPaT way. Hopefully you can recognize it. In this case, around not malaria, say, treatment, but mental health. And I want you all to recognize the criticality of mental health to be in the area of health that you are considering as you work in AI and health, because in many, many parts of the world, including on the African continent, mental health is an area that is really woefully undertreated. And in Liberia, when we first started working there, just 2 years after the end of the Civil War, there was only one professionalized mental health provider in the entire country. One. So nobody really was had access to any sort of professional mental health, though in our own sort of day-to-day experience in the country, we experienced enormous need for mental health support. So please consider mental health and remember that mental health is a critical part of the overall health and wellness programs that you could be working in. Okay, so hopefully what you've seen is that this is 20, 25 years, 2 examples. One, kind of modern LLMs meets cultural bias in African medicine. The second, old school video systems, building a new conversational agent using HCI for development and participatory design tools, all kind of framed within the IPaT way. Thumbs up? A little feedback? Thank you. Because what I'm going to do now, I have gone for my 30 minutes, but I'm going to still take 2 more minutes and give my advertisement. So I'm officially 2 minutes over. And the advertisement is this. IPaT, working with the College of Computing at Georgia Tech, has launched a couple of years ago an initiative called OMS for Africa. OMS stands for the Online Masters in Science, and the Online Masters in Science in Computer Science was founded in 2014, and it's a fully accredited degree program from Georgia Tech that is 100% virtual and online. Now, it's 30 credit hours. It can take 2 to 3 years. 3 years if you're part-time, maybe. 2 years if you're full-time, maybe. 100% online. It costs, if you pay for the entire program, roughly $7,000 US for the master's degree, the whole program. But as part of our OMS for Africa program, we launched OMS for Liberia, where for Liberians, it's free. So OMS-CS is free for the people of Liberia. And we want to increase the number of fellowships we're able to provide on the continent outside of Liberia. And we're slowly expanding. The next place we're probably going to be in is Nigeria. So what is this program, OMS-CS? Forbes magazine, which some of you may know, it's a US-based magazine, has called it the greatest degree program ever, the most successful degree program in the history of higher education. It's kind of crazy, this program. There are right now 13,000 students enrolled in the Online Masters of Science program for computer science. 13,000 students. Some of them, I bet, are here in Rwanda. Definitely some of them are in East Africa, without question. There's already 11,000 graduates and 100+ countries represented. It is the largest degree program on the planet for computer science. And when I say that we've launched this OMS for Africa program, this is not a recruiting program. We do not need more students. We have 13,000 students. Are you kidding me? We have plenty of students. This is a program for partnership with Africa, because we're not satisfied that we are appropriately serving the needs of the African continent with the program, and we want, through partnerships with you, to build a more supportive and available environment for this program, which we think could help upgrade talent at a very high level for people here in Rwanda and beyond. So I welcome you to reach out to me if there's any interest in the OMS-CS program. Thank you for letting me go over and do that advertisement. And then I think there's a little bit of time for Q&A.
Okay, so please introduce yourself and then give your question.
All right, good morning. Thank you, Prof, for your presentation. My name is Eric. I'm from Ghana. I work as a clinical nutritionist with a particular focus on critical care and perioperative nutrition. My question is regards to Charles's work. You mentioned that he, in coming up with a medicine disease pair, looked at PubMed search for data. I'm wondering if you could comment on the limitation of using that approach, given that there are times where certain knowledge are not published. Not everything gets published necessarily, and PubMed is just one database. So what will be the limitation from that approach you use? How did that influence the result you got? And maybe how could it have been mitigated? Then lastly, I'm also interested in an online masters for science for Ghanaians. So I'm representing our country now. I'm wondering how we could probably partner like you are talking about. Thank you very much.
Thank you for those questions. And if anyone, does anyone see Charles? Because he should answer the PubMed question if he's around. In terms of Ghana, we do want to try to do the OMS program in Ghana. We've talked to Ashesi and KNUST in particular as potential partners, but we do not, unlike Nigeria and Liberia, we just, okay, I'm going to be super candid because we're all friends, right? As we all know, these programs need to be resourced and we need to raise funds for them, right? And we don't have any funds right now for a Ghana program. And we haven't had any great prospects or ideas as to where to go. So if you have ideas like that for Ghana, then we would like to pursue them. In Liberia, we are just funding it through our own goodwill, but Liberia is a very small country with very, I'll be again super candid, not very many people in a position to want a master's of computer science. So the numbers are tractable for us to manage out of my own budget. I'm using my budget for that project. For Ghana, for Nigeria, we have Nigerians who really are wanting to give back to their country, who are based in the United States, and that's how we're resourcing that program. So we need to think creatively as a community in all sorts of ways in today's funding environment. You know, this is just one program that if it's of value, we need to think creatively, but I know many of you in this room are you know, wondering the same sort of things. What are the best approaches towards funding your programs? And so I just wanted to be super candid as to what the main constraint is in terms of expansion into Ghana. That said, if you want to just do the program, and if the payment of the funds to do the program is possible for you, then I would really encourage you, and please just reach out to me and I can guide you through some of the process. And Charles, do you want to answer the PubMed question? Did you hear it? You know, basically the question is, how do you trust just PubMed? There's other things to look at. And one thing I would say in terms of that is all of our data sets probably are eligible to those kind of complaints. I went to some of yesterday's data panels and everyone had those kind of limitations. It's just a perennial limitation as we're acquiring data, that the data we're acquiring comes with a slant, maybe even a bias, represents a time and space and a community, and that therefore means it could misrepresent. And I'm sure that that would be the case in this, in the PubMed specific data.
Okay, fabulous. And we have another question at Tiro.
Thank you. Two things that I took away from what you shared was don't create technology and then go and find the problem and the people to match it. Rather start with the people and the problems they have, and then the technology follows. And secondly, that Africa bears 25% of the global disease burden. With that in mind, my question is, in my specific context, which I know is quite big, I'm a data scientist for a health insurance company in South Africa, right? How do I make use of the insights I've learned from you this morning and apply them as a data scientist working in a health insurance company? Because some of this is, you can use research and innovation to move that, but I'm already in a system that exists, but I want to make use of these concepts in my work as a data scientist. Any suggestions?
So we call you a payer. I don't know if you use that phrase, a payer. You are a payer. So we do work in the US in my lab with payers. Payers are the insurance companies. I guess called payers because they're the ones paying for the treatment. They are very hard in the US to work with, and very hard, I think, for folks who work within them to be creative. But here's one way that we at least have found to work with payers, and maybe you as somebody working within that as a data science might be able to help, is you sit on data. And a lot of what we talked about, we were just talking a second ago about the PubMed data and what's the limitations, et cetera, but we all, like the AI, half the time the data is the problem, the model's easy. Or even like the model's trivial and the data is the problem, right? So depending upon what kind of thing you're working on, the data is crazy. You have a treasure trove of data. So one question I might ask is, within the IPaT way structure, within you working within your organization, or maybe even partnering, could that data help to solve people's real health challenges? We have at IPaT a enormous payer data set, meaning we have the data over the last decade of maybe 90% of all insurance transactions in the US. And IPaT has a specially secured data storage and analysis system, because this is patient identifying data, and it falls under, in the US, what we would call HIPAA compliance. But I'm sure in many, many parts of Africa, you all have regulation around patient data security, right? Special security required. So I'm just saying, I'm adding that we actually then have built out a highly secure data system that allows us to make use of this kind of payer data, and it is being used for all sorts of important data studies and data science work. So, so I hope that that's helpful. Yeah.
Okay, fantastic. Thank you, everyone. Can we have a hand for Professor Best? Okay, we're now going to start our lightning talk section, and Marvelous Ajala will be handling that.
Hi, everybody. Can you hear me? Okay, good. Okay. So thank you, everybody, and thank you very much, Professor Best. So as part of our how we engage with the community, one of the things we try to emphasize is ensuring that members of our community are aware of research that other members of the communities are doing. And so this year we also have cohort lightning talks. And we had quite a number of submissions, right? But then we have very limited time. So we have to like prioritize a couple of ones that will be giving the talk this morning. And we have just 3 of them that'll be evaluated on some of these criteria, as you can see on the screen, right? So we'll be looking at the clarity, how are they able to communicate the work, and the relevance. How is it connected, you know, data science and health care, specifically in Africa, because that's what the focus of this workshop is about. We're also looking at potential for impact, right? Let's not just do research for research's sake, but let's do research that has like impact, research, policy, and practical value, and presentation quality and creativity. So as a little just guidelines for how this will go, because we are very short of time, so to take, each speaker has 3 minutes, and sadly, we'll not be able to ask them questions. So I'll advise that you jot down your questions and you ask them personally after the lightning talks if you have any question. And so without much ado, I'll call the first speaker, which is Fadaus Idlasen from Faculty of Medical Sciences and UM6P Hospital, Mohammed VI Polytechnic, Morocco. Thank you.
Hello, thank you so much. So imagine you are a detective, an investigator, trying or standing at a scene of a crime. Evidence could be everywhere, but the problem is that the real mystery is always hidden. And this is in cancer, so the real mystery, usually it's dig in the genes, and the crime scene is usually it's the tissue sample. So pathology, the study of the tissue, has always been the detective in this story, and it is when medical doctors are inspecting under a microscope to lead for decisive treatments. But the problem is that to fully understand cancer, you need to dig more deeper to the genetics. And this is where it gets more bit interesting to the resistance of therapy, which is the plot twist of the story. So the resistance of therapy is happening in many cancers, like the case of the ovarian cancer, which is a building burden where the chemotherapy is suddenly useless. So what the protocol is that they need to detect mutations like BRCA and HRD and add some kind of inhibitors plus the chemotherapy to have an effective treatment. Now the problem, this is considered as a targeted therapy, so some genetic tests are needed. Most of the time they are timely consuming, very high cost, impractical in high HDA setting, so imagine a low HDA setting. So what we need actually is more biomarkers. And this is a question that they are needing to answer through AI, which is something that was not possible before, and now it's possible, is that trying to predict these gene mutations directly from the images without passing through the molecular testing. So this is from the medical aspect. Now, from a computational perspective, this kind of images, a whole slide image is actually comes with struggle. And it is very heavy, it needs some patching, so you cannot annotate everything because you cannot add more burnout to pathologists. So you need something that is a technique that is having higher level, like multiple instance learning. So also, we need to add some attentions because we are looking for something that we don't know, so we need some links. And also, we need to build some on the advancement of foundation models. And the question is how about the spatial relationships? So this is the kind of smooth operator also that we added to link when we patch to link this kind of spatial connection that are lost. So it gave promising results, and we hope that we are going to add more data because we implemented on a Moroccan data, one of its kind, and we are based on UM6P hospitals that are pathology and joined with Universidad de Granada. So thank you, brilliant mind. That was my speech when cells speak genes. Thank you.
Thank you very much. Up next, we'll have Christopher Velasi from INISA, South Africa.
Good morning, Kigali. I'm Christopher Velase. I am from HISP, South Africa. Our team works on making healthcare more actionable. So today, I'll take you through a framework of anticipating dengue outbreaks and enabling a proactive action within healthcare. We have dengue cases from the CDC Public Health Intelligence Report, and that data is mapped by country, and within that country, we have the districts. The challenge is clear. Dengue data is often sparse, inconsistent, and delayed. You have data where sometimes you look at the data, you're like, okay, this could be a blank, or there could be no cases reported for that specific week. And the approach for reinforcement learning is for us to be able to use this sparse data where countries do not have dengue cases by those districts are able to forecast cases for their country. The approach is quite simple. We have a machine learning algorithm, and then there what we do is the pipeline uses a policy gradient approach, and then we use learning step by step to minimize forecasting error. This means we don't just look at the data, we adapt to the noise in real time. And this approach was inspired by a case we've been using in South Africa where we've got an ensemble model that uses Profit, Random Forest, and ADA Boost. And in this model, we have implemented it in DHIS2, and we implemented it in South Africa for forecasting for the South African National Health Department. The forecast outputs cases by district, and then this enables the ministry to react in real time and position supplies, mobilize staff, and prepare responses. Currently within this data, we have population, WASH data, as well as other demographics. In short, we're looking at using reinforcement learning framework where we're going to help shift our health systems to become more proactive and less reactive. Thank you.
Thank you very much. And for the last lightning talk, we'll have Professor Soro Hama from Smart Labs Digital Research Center of Cefax, Tunisia. Welcome, Professor.
So good morning. My talk is entitled Towards Privacy Preserving and Adaptive AI for Healthcare. So when we talk about medical data, the first aspect that we must consider is its sensitivity and confidentiality. This makes data sharing across hospitals and institutions from different countries in Africa, for example, extremely challenging. But collaboration is essential because there are no single hospitals who has enough diverse data to build reliable AI models. One promising approach to address this challenge is federated learning. So instead of centralizing data in a single machine, training is made in a collaborative way where models are trained locally and only the learned parameters are shared to build a global model. In this way, knowledge is exchanged while the data itself remains private locally. But sensitivity is not the only challenge or the only characteristic of medical data. It is also constantly evolving. Think about the sudden emergence of the coronavirus, where models or healthcare systems had to deal with new patterns of disease rapidly. This kind of evolution poses a serious challenge for deep learning models because traditional models are not naturally designed to adapt. And when we expose them with new diseases or with new data related for new diseases, they tend to overwrite the acquired knowledge. This is the phenomena of catastrophic forgetting. For example, a model that was trained to recognize pneumonia may lose its accuracy on pneumonia when it is retrained to detect coronavirus. Now, federated learning faces the same problem, and we cannot usually or simply retrain all models each time a new disease emerges, especially when data is decentralized and distributed across multiple institutions. So that we propose here is to integrate continual learning into federated systems. This means that we aim to allow models to learn incrementally, to remember what they have already learned while adapting to new diseases. So the core idea of our approach is to compute weight importance matrices for each task and use them during training to mitigate the catastrophic forgetting phenomenon, while preserving essential knowledge across tasks. So in short, our approach opens a promising way because it provides us a practical and scalable framework for building AI systems that evolve with medicine, remains reliable across institutions, and respect patient confidentiality. So thank you.
Thank you very much. So in case you have any questions for them, you can meet them after. Thank you. I'll call on Tali now, who will lead the panel session for the state of AI in our healthcare research in Africa.
Sure. So around the world, artificial intelligence is transforming the way that healthcare has been rolled out, not just in diagnostics, but also in terms of patient engagement. However, the African context is unique. As mentioned, we have one of the highest infectious diseases burdens. We have a multilingual population and infrastructure constraints. But at the same time, Africa has a lot of potential, not only with the way that we are able to bring together communities, but also the way that we have been able to really bring together diverse people to solutionize and, leapfrog over traditional systems. So this panel has 3 objectives. The first of which is to try and understand the current landscape with a focus on the most promising foundational AI systems that can be applied within the African landscape. The second of which is to identify pathways to take research into real-world impact and identify some of the constraints. And lastly, what are the current opportunities for people in the audience to get involved? Are there ways that you can immediately start improving the healthcare infrastructure within your countries? So over the next 35 minutes, we will listen to our expert panel, and then hopefully we will also have time to take some questions from the audience. So I would like to now call up our speakers. So the first one you've already heard from is Professor Michael Best. He is a professor of international affairs and interactive computing at Georgia Institute for Technology. So Michael, if you want to come and sit at the second chair over here. We next have Dr. Rose Nakasi, who is the head of the Makerere University AI Health Lab. We next have Dr. Arjit Patra, who is a senior principal scientist at UCB Biopharma UK as well as an associate professor at the University of Glasgow. We next have Dr. Toby Ulutanji, who is a machine learning scientist and founder and CEO of Intron Health. And within the same AI startup space, we also have Jay Patel, who is the Director of Technology at Jacaranda Health. Okay, so thank you everybody for joining us for this panel discussion. To begin, I'd like to invite each of our speakers to share a bit about their current work and also highlight one or two experiences that have shaped your perspective on AI healthcare research in Africa. And we can start from Michael and then work our way down to Jay.
I'm going to speak very little on this panel because you guys already heard plenty from me. I think I'll pass on that question actually because I'd rather hear from other folks. Is that okay?
That's fine.
Thank you very much. And good morning, Chigali. Happy and privileged to be part of this conversation on artificial intelligence for healthcare in Africa. And I bring you greetings from the Makerere AI Health Lab from Makerere University. I'll go straight to the question that you've asked about what are some of the promising works that we're doing around the space of artificial intelligence in healthcare and what opportunities have motivated part of the work that we are conducting. I'll bring to the attention of the audience here the project called Ocular. The project called Ocular is motivated, one, by some of the most pressing public health care challenges that we face in Africa with diseases such as malaria, tuberculosis, cancers, and also looking at the gold standard mechanism of how those diseases are diagnosed, for example, for malaria and cancer, which is by the use of the microscope. Motivation behind this was the lack of enough expertise, especially to man this technology, that is the pathologists and the microscopists at the point of care. Actually, in most of our healthy facilities, especially in the remote parts of the country, we literally lack pathologists. In Uganda, we have only one cancer institute, which is based actually in Kampala, so that leaves most of the other places with lack of pathologists to be able to carry out the diagnosis. And we know that the primary control of a disease lies around how you diagnose it, because the right diagnosis will trigger down and provide ripple effects of better treatment and better patient care at the end of the day. So what we're doing is that we're utilizing the already existing equipment at the points of care because we want integration to be seamless. And the idea of applying artificial intelligence is, can we have tools that can be integratable within the already existing healthcare system. So we're relying on microscopes that are already at the points of care. Almost there is a microscope at all the public health facilities in the country. The other thing that we're also looking at, that even within these disease-burdened settings, we also have other equipment such as smartphones. So the idea is, can we be able to rely on some of these existing equipment, but also leverage and harness the capabilities of artificial intelligence to be able to support the way these diseases are diagnosed. So what we did is that we developed a 3D printable adapter attachable to the eyepiece of the microscope to be able to, capture images and utilize artificial intelligence to support the experts at the points of care to quickly diagnose some of these diseases. The scale out of this is that where it has been taking a microscopist to view those malaria parasites, small as they are, technically it takes them not less than 30 minutes to do a diagnosis. And when it gets to other aspects of, for example, doing parasitemia identification, where they have to manually actually count these parasites, count the white blood cells, and use the formulation of the WHO guideline to diagnose and to provide statistics for parasitemia determination, it will take them more than 2 hours. So you realize that if we have a very big burden, that means some of the patients are either going to go without a diagnosis in time, or it's going to take them quite long. So those are some of the disruptive technologies that we're utilizing. And the motivation behind them is that, one, we are looking at a contextual solution. We're looking at some of the most pressing public health, burdens that we have, and leveraging on the technology to be able to support the public health care system. We're scaling it up to also provide real-time disease surveillance, and we're also utilizing artificial intelligence to, be able to communicate to patients in languages that they are able to understand, more disrupting and sensitization of the technology, so that at the end of the day we have trust within and in communities where these technologies are going to be adapted, and so many others. Thank you.
Okay. Hello, everyone. So I'm Arijit, and presently I'm a senior principal scientist at UCB Pharma and have a concurrent affiliation as an honorary senior lecturer at the University of Glasgow. Now, on a day-to-day job these days, I find myself kind of grappling with the question of, for all the hype of artificial intelligence for discovering new medicinal candidates, what happens after that hype, after candidate nomination is performed? So what happens when you were to validate drug safety and efficacy, when you have to recruit patients for clinical trials, when you have to actually administer clinical trials and eventually get drugs out there in the market? So I look into, essentially, as I introduce myself, machine learning for everything that is not early discovery. And chiefly among those today, we work a lot into looking into how we can do away with the need to test on animal models and, sort of essentially sacrifice the numbers and volumes of animals that we do today, because that is highly non-sustainable and also highly non-conclusive to eventual drug successes in the wild, in the post-market surveillance stages. So we do a lot of work on building essentially digital systems, including but not limited to foundation models for pathology of animals, and also other kinds of monitoring of evolution of toxicity, and so similar kinds of manifestations at the tissue level within those animal models, but on a digital scale that can eventually tie into lab-on-a-chip systems in the future. Apart from that, I also find myself engaged a lot in patient data analytics and biology understanding and patient understanding. And one of the things that, that does introduce me on a daily basis, like when I look into essentially how clinical trial recruitments happen and how we have historically approached the question of patient understanding, this continent, the continent of Africa, has been severely written off, has been missed, despite having kind of possibly the highest diversity as regards, sort of the genetics that you see in the populations here. And today, obviously, we are at a cusp where this is set to dramatically change with recent initiatives by AMREF and others to ensure that there is a leapfrogging into sort of both early discovery and generally biopharma R&D, as also in generics manufacturing and more sort of last mile supply chain integrations, etc., in this continent itself, including specifically in Rwanda, where you have the likes of Pfizer, etc., setting up vaccine manufacturing in the near future. So I think the time is ripe to have this conversation around how we might improve the representation of patient cohorts from the continent, how we might actually improve even the broader standing of the continent as regards the discovery of new molecules, integrating obviously a lot of the historical knowledge that has emanated from here as well. And in fact, before kind of doing what I do now, I worked a lot on maternal health in machine learning for essentially pregnancy monitoring and ultrasound image analysis during my DPhil. And this idea of translating machine learning innovation into low resource setting, something does not sit right with me. Particularly with the phrase low resource, low financial resource, and cannot be conflated with, a generalized term for low resource, because you are, when you kind of talk about this narrative of deploying machine learning into low resource, low cost solutions, you kind of have this psychological imperative towards writing off the local knowledge and writing off local expertise, and therefore any need for training those or integrating those into your thought process. And that is something, kind of one of those kind of things that did not sit quite right with me, and something that I just wanted to mention as an offside. So today, I think in this panel, we'll try to address both the questions. hopefully looking into both the technical aspects of like health innovation in this continent, and also to an extent look into essentially the cultural and psychological barriers that has historically prevented from, you know, a lot more mainstream discussions around the same. So looking forward to this.
Okay. All right. Hi everyone. My name is Toby. I lead the team at Intron. The focus of most of my work is voice recognition. So if you think about your doctor visits, many countries are trying to roll out electronic health records today, and they put a laptop in front of a doctor and say, hey, now that you have this computer, your life is going to change. Like healthcare is going to be so much better because we have now software in the hospital. But everyone forgets that the person that needs to enter that data. So for example, when I was a doctor in Nigeria, we would see on average 30, 40, 50 patients a day. And so if I have a computer and I have to enter notes, it means you're telling me to type, say 20, 30, 40 pages of notes every single day. As good as your electronic medical record vision is fantastic, the person that has to do that work can't cope because I'm already seeing 40, 50 patients every day. I can't add that much, that many hours of typing on the keyboard, entering data. And so we figured out there must be a way to make this a little easier for doctors because we definitely need that data for policymaking, decision support. And we came up with a way to build models that understand speech from African doctors, nurses. We're currently working across about six countries, working in hospitals, everyday doctors, nurses to do their notes, and we're able to bring down the amount of time they spend on the keyboard by about 3 to 4 times by switching them to voice, basically.
Morning, I'm Jay Patel, Director of Technology at Jacaranda Health. My story is not very interesting, so I'll tell you the story of one of the moms who we serve. Her name is Millicent. She lives in rural Kenya. She owns a feature phone. And I want to speak about her 2 pregnancies. During her first pregnancy, she was late 7 or 8 months pregnant, started experiencing a headache. And she did what we all would do, is basically take a painkiller. Headache didn't go away. In fact, it got worse. It was a couple of hours before she decided, okay, let me go to a hospital. But she lives more than an hour away from the nearest hospital, so it took a little bit of time to get there. What she didn't realize is that a headache during that stage of pregnancy is a potential sign of preeclampsia or high blood pressure. And that delay in getting to care, unfortunately, resulted in a miscarriage or stillbirth. Why didn't she just Google it? Well, she has a feature phone. She doesn't have access to Google, WhatsApp even. Her sources of advice are her friends and neighbors. If I listened to my neighbor's advice, I'd be dead or in jail. So fast forward to her second pregnancy, she had signed up for our service we call Prompts. When she signs up, we were able to send her over SMS health information tips, what to eat during pregnancy, what to avoid, but critically she could ask us questions. And she did. She asked a few dozen questions during the course of her pregnancy. Most were benign. What do I eat? Is it okay to eat avocados? And most of those were answered by a Swahili-speaking language model that we've deployed. Again, she had the headache, preeclampsia, asked the question, I have a headache, what do I do? The system flagged that as urgent, alerted a help desk agent who called her and told her, listen, this is a problem, you need to get to a hospital now, which she fortunately was able to get the care she needed, and a few weeks later she delivered a happy, healthy baby boy. But Millicent's not alone. We get 12,000 questions a day from moms across Kenya, slowly more across Ghana and Nigeria as well. And I think that's, this is a very technology and AI-focused conference. That's one example of how technology can actually be used at scale to help impact lives.
Thank you, everyone. We've already heard about some of the challenges that AI in healthcare, specifically applied to African context, would face. So this question is for Rose, Jay, and Toby, because you guys are either based in Africa or have on-ground startups trying to address some of these problems. What have been the most critical barriers that you've seen for AI healthcare projects in Africa that need to kind of overcome to succeed? And what strategies have you seen that have helped turn those barriers into opportunities? And we can start with Rose and then once more make our way down to Jay. And I'm sorry for the order, I will reverse it for future questions.
Yes, thank you. And I'm happy to share part of the experiences along the work that you've been working on. Contextual. As we know that artificial intelligence models are as good as the data that they consume, and therefore data plays a very critical role in the way models are developed and the outcomes that they produce at the end of the day. So data from our context, one, if you're to bring it back to the context of the African context, most of the publicly available data, as we're beginning this work on Ocular, was more of the data that was coming in from the western part of the world. So what that meant is that, well, it will give us very good insights, but having it fine-tuned to the local context was not available. So one of the challenges that we faced was actually the data, the unavailability, because for AI models to work well, we need data to be accessible, but also to provide that contextual inclination to whatever is going to be as insights that are going to be drawn from the models that they are developing. The other bigger challenge was the infrastructure, because these are digital tools we're talking about. Data needs to move from one point to the other. That means we need to have an internet infrastructure to move that data from wherever health facility we are collecting it from to curate it into a centralized database. In Africa, you'd realize that much as, yes, there is internet connectivity, but when it goes deep down to the remote parts of the country, we're still grappling with that infrastructural challenge, not only internet connectivity, but also the electricity component, because for us, in our context, we're looking at powering up the microscopes, powering up the smartphones to be able to, capture this data. So some of those are some of the challenges that we are still grappling with, and reaching out to governments to be able to provide us with a very robust infrastructural, that can support uptake of artificial intelligence tools. We can't be able to develop tools that are going to lie in silos in labs. There has to be an enabling environment to have, adoption and integration of these tools within the health facility. Looking at medicine and healthcare as one of the most sensitive domains, very highly regulated. And we're looking at a scenario currently, especially in Africa, where artificial intelligence modeling or tools are outpacing the regulatory or legal framework within the country. So what that then means is that there is a lot of development that is going on, technological advancements, but then we're seeing the regulations that are supposed to provide the enabling environment to uptake some of these tools still in its infancy. Actually, when you do a very simple search, you realize that there are very few countries in Africa that have already developed artificial intelligence policies to enable or to provide guidelines on which developers are going to base to implement and integrate. And when it comes to healthcare, actually we have very few. Governments are still grappling with developing some of those guidelines and frameworks that are going to provide this enabling environment. For us, that has been one of the, limiting factors, because we're developing, but we don't have that environment to be able to allow us to integrate. And that demotivates further developments.
Okay, thank you, Rose. We'll now move on to Toby and Jay. Very, very insightful with the regulation.
I'll go back to Professor Best's point, where, okay, you have this cool AI model, so what? The technology, especially now, technology is often not the difficult part. The difficult part is the integration. How do you get it in front of you, into the hands of users in a way that is going to help them? How do you integrate with the health system and make sure that you're closing the loop between sending a mom to care, making sure that she does get the care? How do you set it up? How do you design it so that it's contextually, culturally relevant? What we found is that you can send a very clinically accurate message or response to a question, but if it's not understandable, then people won't action on it. They may not even bother to read it. So it has to be designed and deployed in a context that makes sense for users, and that language and level that they understand, and at the level of technology that they have access to. And then also, how do you work with the health system, work with the government and the providers that in a way that they don't feel threatened, like their jobs are on the line. And in fact, that they're so bought into the efforts that maybe they want to help you because it makes their life easier. So these are the conversations or the kind of considerations which are much more difficult, much harder to scale up, you know, and it's, I think, much more interesting than throwing more compute at a problem when it comes to scale.
Yeah, really great examples. I think mine are similar as well. Data is, of course, like she said, when we started, there was no data in the world on like African voices or African accents in the healthcare space. There was zero. So we had to start from scratch, like talking to my friends, can you do like a few sentences? And of course, that has grown quite a bit. I feel like we've figured out how to collect data in healthcare. So I think that's much better right now. Infrastructure, like she said, power, those are just basics everywhere. But I think for us, some very unique things, since we work with doctors' clinics and we work with hospitals that already have an electronic health record, there is an additional layer of integrating, like he said, into the existing workflow, existing tools. And we find two really interesting bottlenecks. One is hospital IT teams who, so for some reason, they don't even understand the system that's installed in there. So we're like, there's this really cool tool. The hospital has approved, signed off, even paid in some instances. Now let's integrate, and like, don't touch that server. If you touch it, everything goes off, and you're like, okay. So what do we? And there are very, very interesting experiences we've had at different hospitals. The second layer to that is, even if you have the IT support, they're probably using an EMR vendor from God knows where, some countries, some locally built, and you find that the EMR vendor themselves, they don't even have the capacity to upgrade their system. They weren't planning to upgrade at any, so there was one that told us that we would need to pay them to go to each of their hospital sites and plug in a flash drive and install our system and upgrade. And I'm like, that is definitely a headache. So just some really interesting experiences. And if you guys are planning to do stuff in healthcare, please get ready for systems that will be tough to integrate, but yeah, still possible.
Very interesting. And I guess moving to Arjit and Michael, having done your PhDs and also being based in the global north, what lessons do you think Africa can learn from the way that healthcare and AI has been integrated? And in addition, what innovations from Africa do you think that the rest of the world should be paying attention to? So there's two parts. The first is, what do you think Africa can learn from the global north's healthcare rollout in AI? And the second part, what can the rest of the world learn from Africa?
Yes. So this is an interesting, question in both parts. Now, for me personally, so I grew up in India. I'm from India, did my undergrad in India, and only moved here to the UK for my PhD, and sort of worked in. Obviously, the PhD was around dealing with a lot of healthcare data and the UK healthcare stack. focused on obviously the applications in the global south, but still we would interact a lot with the NHS of the UK. And one of the observations that I made, like even when I think about say comparing Indian healthcare with systems like the NHS, is that the question is that what is that inflection point when a state's priority shifts from essentially distributed private healthcare or even public healthcare to having a national body like the NHS. For the UK, that happened in 1948, following World War II and the consequent labor shortages, not so much of doctors, but of nurses and paramedics. So that was a very unique inflection point when this happened. And a lot of the initial funding came from a lot of the reconstruction efforts, the Marshall Plan, for example. So that was a very unique set of circumstances in which a body like that was born. Now, when you talk about, say, the reality of healthcare in the global south versus the systems and processes that you see in the global north, I would actually take it in two parts. One is that what not to learn and what to learn. So first, in my view, what not to learn or what not to adopt from the global north, something that possibly multilaterals and aid organizations, etc., would very well to pay attention to, is that you should not kind of assume that the systems and processes and the process-driven thinking would necessarily be transferable to the global south, where a lot of the administration of healthcare at the last mile is not fundamentally individualistic, but more on a community basis. So there is a very strong cultural prior to healthcare administration in the global south that is not necessarily the case in the global north. And in fact, as an aside, when the populations in the global north increasingly have migrations from the global south, this is something that their policymakers simply increasingly fail to grasp. And that leads to sometimes borderline racist commentary about these populations. Frankly, it's just a lack of or a political lack of willingness to understand that there can be differences in how systems and processes might need to shape to different cultural backgrounds and different ways of community organization. So the first thing not to learn is that systems and processes are the end all and be all. They're simply not. At the end of the day, healthcare in the global south is a community-led process at the last mile. It is essentially a community-driven compromise. It is fundamentally, if I could say so, you need to kind of like think a little more in terms of the Ubuntu way of thinking as opposed to the Kantian materialism way of thinking about healthcare. And that should influence like delivery and this thing. Now, what should be learned? So one of the things that we have seen, particularly in the developed world, over the last, sort of few decades, post-World War II again, is that there has been kind of a very strong focus on integrating technology into the healthcare value chain. Now, we could say that a lot of these things are fundamentally capital intensive and simply would not translate into the global south. But let's think about how we can make the global south healthcare stack more technically driven, not talking about technology from a global north perspective, but from very much a global south perspective. So for us, technology might very well mean integrating technology would be finding out solutions to the, the repeated power outages in a clinical setting, or something like that. You would not have, for example, let's say a very robust way of actually transferring healthcare apps in a manner that you would do in an European market. And so what are those technical solutions that are specific to our situations here in the global south? So it's more of the thinking space that I'm talking about. So, like can very well take the lead on kind of like building low-cost solutions for digitizing handwritten clinic, sort of like medicine prescriptions and using those to, for example, build kind of like question and answer chatbots for the patient level. So, it's more on the thinking space. So that's something to be learned. Now, to briefly answer the rest of the, the question that what the global north might want to learn from, Africa in general, I think, the global north really needs to learn a bit about community and a sense of community being important to healthcare administration at the last mile. Not everything can be done by essentially by a strong state or essentially by a state monopoly on healthcare or by let's say a private insurance monopoly on healthcare. Fundamentally, most healthcare is a community process. Even in deeply individualistic societies, healthcare at the end of the day is not just an individual project. Like when you have, let's say, even, things like sort of like mass lockdowns due to pandemics, for example, that is something that a point that was driven home, that a lot of these systems simply fail to cope up on how to actually kind of traverse that bridge between the individual and the community. So I think that community-based thinking about healthcare is something that the global north certainly needs to learn from the global south. So moving on to Michael in the interest of time.
Thank you very much. It's a good question, and Arjit, I really resonated with a lot of what you said. First, though, I would maybe start by critiquing a little bit like the global north, global south dichotomy. I know many of us often are confronted with this division and then realize there there are imperfections. So in the case of the global north in particular, I think what is happening in USA is different than the EU, is different than other parts of the Northern Hemisphere. We see that in particular in AI policy, which is something that is critical. And Her Excellency yesterday in the policy panel, I think really elucidated the AI policy agenda, which I think is quite strong and interesting and in alignment in some ways with EU policy agenda and in disalignment with the US federal government policy agenda. And so we can't compare all of the global north because the EU agenda is very sort of regulatory. First, I would say the US agenda is we're the winners, we're gonna smash you all. And then the China agenda is, at least the the China AI policy that came out really just last month, I think, is sort of kumbaya, let's all get together, the United Nations will help us, let's make the world better. Now, we can also be cynical about all of that part. I'm not sure we can be cynical about the US because I think that really is the federal government's opinion. We need to win and screw you, we're gonna win. So the point being that there's a distinctions between different parts of the North and the South. And so we should always keep that in mind. From the US, though, there still are things to learn. One of it is slow down, in my estimation. The new idea of a return of move fast and break things, which is being applied within the AI space currently, and complete deregulation is sort of something to learn to not do. I think the risks are very significant. And if you are looking at high importance sectors like healthcare, then all those risks just get more salient. And so I think we need to not learn the lesson of whoever is fastest is going to be best. And by fastest, I mean getting product to market fastest. And from Africa, there is a lot to learn, of course, but one of the things that I was struck at yesterday and realizing that I was kind of being a jerk most of the time is that the work being done here that is more focused on sustainable AI is so important. And as examples of that was the many, many posters I saw where people were working with small models. And then I'd be like, I wonder if you added 1,000 more parameters or 10,000 more parameters, you have to be up in the trillions, you're in the billions. And the reaction is, well, that's not a sustainable model right now. And that's not just not sustainable in Africa. In terms of environmental sustainability, that's not sustainable worldwide. And so we need to learn from Africa this, really clear focus on sustainability. We know that in my city, Atlanta, and many parts of the world that I work in, where data centers are coming with crushing demands for electric power and water, and it's just not a sustainable situation. And then finally, I would actually suggest that we view a lot of these issues as global. So I'm co-running a program where we're looking at rural diabetes and digital responses to diabetes management in rural Tamil Nadu in the south of India and in rural Georgia, the state of Georgia, where Georgia Tech is in the United States. And we did these really exciting consultations with practitioners and folks dealing with prediabetes and diabetes in these two parts of the world. I tell you, rural India and rural Georgia, there is not a big difference between the issues they're dealing with. In rural Georgia, they have flip phones. They don't have smartphones, some of these people. They're in food deserts and they are food insecure. They have no access to healthcare because there's just nobody around. So when we really, really dove down with these community members, it was not a global north, global south situation. It was rurality in conditions where for all sorts of different reasons, there's scarcity of various social, medical, technical infrastructures.
Thank you so much, Michael. And I think it's a very important point to consider, like the contexts between different countries, because every country will have different approaches to how they are going to be rolling out the AI. Moving to scalability of solutions. So this is specifically for Toby and Jay within the startup world. What are the most overlooked factors that are preventing pilots from being able to actually be integrated into healthcare systems and make an impact within the communities that they're trying to serve?
Great question. I think one of the issues that I think even we are currently grappling with is evidence, because I mean, I was talking to my team last week and they were sharing about some of the struggles they had with some hospitals. And I think one of the things I was sharing is evidence is because people might feel, so let's say I'm a doctor, I'm very busy. You have this fantastic tool, you're like, yay, it'll make your life better. I'm like, yeah, I have enough patients, I have it. How am I sure this is, you want me to make a change in my life right now? How am I certain that if I put in the effort, I will get results? And sometimes that's if you blow that opinion up to a national level, you find that you see some degree of inertia. When everybody's like, yeah, you have this cool tool, it's great, but we're going to have to invest some effort to integrate it. Will it be worth that effort? And so that's why pilots start.